now it's time for our last keynote speech. And the speaker is Professor Raymond from Ulster University, Northern Ireland. Ray?
It's really a real privilege to be here and to give a talk. If my talk is as good as my dancing, then we'll be okay, all right? Okay, so I'll go straight into it. I'm going to talk about digital mental health and make a case for it. Now, you can make a case for it, but you can also make a case against it, and I would like to see a keynote at some point in the future making a case against it. Okay, let's start. I am a computer scientist, okay? So I'm not a mental health expert, but I will be talking about mental health at times. In computer science, I love this quote that the two hardest problems in computer science are people, and two, convincing computer scientists that the hardest problem in computer science is people, right? And so I typically take an interest, a research interest, on the intersection between people and technology. So when we talk about digital mental health, this is the kind of technologies that we're talking about. This is a spectrum of technologies from digital interventions right through to the use of data science and AI. So you have things like virtual reality, where you can do things like exposure therapy. Now, the really good thing about using VR for exposure therapy is that you have full control of the variables. So if you have a fear of elevators, you can simulate a fairly low fidelity elevator and allow somebody to experience what it's like to get into a large elevator. Then at the next iteration, you can show them what it's like to get into a smaller elevator. And the next iteration could be getting into a small elevator with other people. And so you can easily progress the fidelity of the exposure therapy. And there's simulation-based training where you can simulate different scenarios with counsellors and psychotherapists for training purposes. And you can use VR for empathy machines. You can expose people to a worldview or what it's like to live in somebody else's shoes. And the more empathic we are as people, the more reasonable we are with each other. The more empathic we are, the more empathy we have, the more reasonable we are with each other, which should make sense. Digital health apps are probably the most popular. You've got psychoeducational apps, mood tracking, apps to manage your sleep, and so on. Then you've got NLP, which is the use of AI to understand text. You've all heard of Alexa and smart speakers. There's many applications there, and I'll talk about chatbots later on. One other application is that if a counsellor is delivering online text-based CBT, you can have NLP or AI recommending responses that standardized responses that are, evidence-based that the therapist can choose to respond with. And obviously that speeds up the conversation and allows you to have high-quality responses to the client. Data science is something we also specialize in. We're doing all sorts of data science projects like clustering to understand callers in helplines, process mining with psychological therapy services at hospitals to understand the different patient pathways. And we're also doing machine learning where you can predict outcomes and so on. So that's digital mental health. Now, why do we need digital mental health? You already know the statistics. I don't. So when I read the statistics as a computer scientist, it is really surprising that most people with a mental ill health don't have treatment. Some statistics say up to 70% of people who have a mental ill health don't receive treatment from a healthcare professional. And of course, there's lots of waiting lists. And there's some statistics, for example, that whilst on a waiting list, 1 in 6 people can attempt suicide, 4 in 10 self-harm, and 2 out of 3 deteriorate. So being on a waiting list for talking therapies is also dangerous for these patients and clients. So these are the other reasons that I will present just now. They're very obvious, hopefully. These are the reasons why I think we need digital mental health. And I'll focus at this point on digital mental health interventions as opposed to data science. So we're talking about digital health apps over the next number of slides as opposed to data science. Okay, the first one is pretty obvious. If you have an app, it's available 24 hours. The client or user can remain anonymous, and there's no stigmatization. And this is a quote actually from a workshop participant on our ChatPal project, which I'm sure you've heard about already. And I thought this quote sums it up, that if a client uses a chatbot to receive coaching around mental well-being, according to this workshop participant, the client might open up because the chatbot isn't human and the user doesn't feel judged. And also the chatbot might be good for people who need face-to-face human support, but they aren't quite ready for it, or they may not have the courage to step out and to get talking therapies or other types of treatment. So it's kind of like a stepped care model where the first point or the first step is really digital psychoeducation and perhaps a mental health chatbot such as ChatPal. So accessibility, that's obvious. Inclusion, anybody can use the app if they have an internet connection and so on. But the other reason is polydigital. Yes, it's a term that I just made up, but we talk about polypharmacy, the management of multiple medications, which is quite common. But in the digital mental health space, you can have a sleep app to manage your sleep hygiene. You can have a mood tracker app to manage your mood. You can have a psychoeducational app to educate yourself about mental health literacy. You can have another app to engage in breathing exercises and mindfulness. So you do have this kind of polydigital. And because to quote or to paraphrase Julie Smith, you can't build a house with just one tool. So in the digital space, you can have lots of tools, and each one of those tools can provide a 1% improvement in your mental well-being, which reminds me of this idea of the aggregation of marginal gains. So a sleep app might just improve your overall mental well-being by a little bit. A mindfulness app might improve your overall well-being by a little bit. But the aggregation of lots of 1% improvements is a large improvement, right? So it's the idea of the aggregation of marginal gains. And which reminds me of the story that James Clear tells in his book, Atomic Habits. Hopefully some of you would have read it or know about it. And he tells the story of the British cycling team, who were very bad at cycling. They'd never won the Tour de France. So they brought in a new manager called Brailsford. And his philosophy was the aggregation of marginal gains. And so he started out improving small things like the ergonomics of the bike, the weight of the tires, which are all very obvious. But then he looked for the 1% marginal gains, like the pillow that the cyclist would sleep on. And they would bring that pillow to all the hotels and so on, because the pillow improved sleep quality just by perhaps 1%, okay? And they looked for other improvements like the massage gel that they would use. And they even taught the cyclists how to wash their hands so that they wouldn't get any small infection that would affect their performance. So all those 1% marginal gains resulted in the British cycling team winning the Tour de France and winning 70% of the medals at the Olympic Games. So the polydigital, having lots of apps to manage small things, because we know mental well-being is multifactorial, you can have lots of digital tools to help you improve different aspects of our lives, which can aggregate to really make a big difference. Okay, another reason for digital mental health is, of course, the prevention aspect of it. And this is very obvious. I think lots of us have talked about this. As a parent, we teach our children to brush their teeth to prevent tooth decay. But what do we give to people to prevent mental ill health? What coping strategies and resilience and frameworks do we give to people to be resilient? and to manage their mental well-being. And this is exactly what our ChatPal chatbot is. The ChatPal chatbot delivers and coaches the user using positive psychology content, mainly the PERMA content. PERMA was developed by Martin Seligman, and the idea is that if you want a positive mindset, you need to have positive emotions. You need to have engagement with hobbies or your job, that is, getting into the flow state. We need to have relationships, meaning, and we need to have accomplishment or attainment. That is, we should always be walking towards a destination in life. We should never be stagnant. We should always be trying to attain something. Even if it was to attain a beautiful garden, there has to always be something that we're looking to attain according to this framework. And so, as a computer scientist working in the ChatPal project, learning about PERMA and other frameworks like that was a revelation to me, because I realized, actually, I really need to know that when I'm 17 or 18 years old or younger, because I need to understand what I need to do to prevent mental ill health and to promote a positive mindset throughout life. And I love this quote by Dale Carnegie, which illustrates the idea of positive psychology, which is that two men looked out from prison bars. One saw the mud and the other saw the stars. So the idea of ChatPal is to let people see the stars and see the glass that is half full. Okay, the other reason for, or the other case for digital mental health is that the data you get is of much higher resolution than the data you would get in a trial or in another research project. Because how people behave when they're supervised, according to the Hawthorne effect, how people behave when they're supervised is very different as to how they behave in the real world. So how people behave in a trial and how they engage with even a digital intervention in a trial might be a bit different as to how they would engage in their own environment, in the real world, when nobody's looking. And I love this example that I'm showing in the slide, which is you can design a perfect intervention with a beautiful pathway, and of course, in the real world, users take their own route. Okay, as I said, digital mental health provides real-world data, and that includes, for example, log data. So every time somebody interacts with the digital app, you can log the date and time and the feature in the app that they were using, okay? And that generates a large database of log data, which allows you to really understand the usage of the app, how real-world users engage with the app. So we call that implicit data, because the user isn't always aware that they're creating data when they're using the app. But there is an explicit form of data collection in digital mental health, which is called ecological momentary assessment. This is pop-up questions that they would be asked during the use of the app. Now, it's important to get data from the client when they're using the app, because the data that you collect is going to reflect how they feel about the app or how they feel in that moment. And so with EMA questions, it's usually a single question from a scale. Let's say you can pick a question from PHQ-9, for example, and that would pop up in the app, and the user would answer that question. So it's very convenient to answer one question for the user, so they're likely to answer it. But the idea is that you get repeated measures. You get a high-resolution data from the end user, whereas in other therapies where there is no digital, you probably lack high-resolution data, because you might only get some diary data at best, or you might only get any data that you collect at monthly therapy sessions. So, to give you an analogy, you can see the slide, you can try and interpret it. You probably struggle to even find out what this slide really is. So, what EMA does in mental health is that it gives you the full picture. And it's a bit like in radiography, giving this slide to a radiologist and asking them to interpret it. Of course, it would be impossible to interpret this data from a patient, because it has some missing data, right? This is the full picture, and this is the low resolution picture that you kind of get if you're only collecting data on a monthly basis in therapy sessions. Whereas having a digital tool to collect EMA data, you're getting a fuller picture that allows the therapist to really understand the client. So we've done this in a number of apps. One app is the Inspired app, which allows people with dementia to reminisce. Okay, and we logged every interaction with that app, and so we could see what time of day people actually reminisce. And you can see that there are three main parts of the day when people reminisce using this app. So people with dementia tend to reminisce just after breakfast, around 10 o'clock. They tend to reminisce after lunch, maybe 2 or 3 o'clock. And they tend to reminisce at 8 p.m. at night. Okay? And you can see that morning and night, 10 a.m. in the morning and 8 p.m. at night are the two most prominent times at which people with dementia prefer to reminisce. That's the type of real-world data that you get. It wasn't in a lab, it was in their own homes, it was in the real world. And so now we can understand engagement. And we do some other data science tricks to try and understand these users. We can characterize the users based on the frequency of use and the favorite hour of the day, and then we can do clustering to work out what are the types of users that we have with this app. And you can see that we found, in this case, 4 types of users. We only had one hooked adopter that used it a lot. And then you have another group that disengaged, and they were irregular at using the app, and so on. So the real-world data here allows you to really understand the clients. In the Inspired Wellbeing app, we also had EMA questions, pop-up questions. And these questions were actually from a mutuality scale, because we were interested in knowing if reminiscing improves your mutuality with your partner or your spouse. So by mutuality, what we simply mean is how close you feel to your spouse. And indeed, we did show that reminiscing does improve mutuality, but we wanted to collect mutuality scale data through EMA pop-up questions so that we can get their feeling of mutuality during the experience of doing reminiscing, not 2 weeks after, right? And this is the other benefit of EMA, is that if I was to ask you to rate your back pain 2 weeks later at the GP, you might give a very different rating than giving your rating during the back pain, okay? So EMA really allows you to have more valid, as well as repeated measures, more valid measures as well. And what we measured here in the Inspired app is the dismissal rate. So when an EMA question popped up, the user could actually dismiss it and not answer it. And so what we looked at is the dismissal rate over hours of the day, and you can see that people are more likely to answer these EMA questions at 9 p.m. at night. Okay? So if you want to collect repeated measures through digital EMA, then they should pop up at 9 p.m. at night. Now, the problem with that is that you're going to be biased towards having data around that time frame of evening. So you might want to also think about trying to encourage EMA data collection at the other times. Okay, we have also done some EMA data collection through another app, a maternal mental health app. And this EMA is very simple. It's just mood logging. So it's pop-up questions or mood logging. And the problem here is that the users were actually encouraged to log their mood at 3 points during the day. But nevertheless, what we find is that people are more willing to log their mood in the evening, about 8 p.m. at night. So it's very similar to the previous findings, that it seems to be that 8 p.m. and 9 p.m. at night are the times at which people are more willing to voluntarily give data to an app, right, if you're collecting digital EMA data. So people are more willing to log their moods 3 times during the day, but most willing in the evening at 8 p.m. But what we also found in this app is that the app also had full scales, right, which wasn't just one question. So it was also collecting full-scale data. But so if you want to collect full scale data, like a mental health scale like PHQ-9, people are more willing to provide all of that data late at night, and they're very, very, very unlikely to provide all of that data during the morning. And you can see that in the second graph. As time goes on, there's more completions of full-scale data. Okay, so another reason for digital mental health is that you're future-proofing. You're providing digital interventions for future generations. And we know that, this generation is much more familiar with digital technology than the previous generation. So I had to find a nice photograph of a young person to put into this slide, okay? And this was maybe 5 or 6 years ago, so I was much younger. Anyway, this generation is also known as Generation Mute because they use smartphones not to make phone calls, but to use WhatsApp and text messaging. So they probably shouldn't be called smartphones or phones at all, because we use them for many more other things like email than just making phone calls. So we need to design for future generations. Another reason for digital mental health is that adding digital to traditional services or established services enhances those services. And digital technology can be the digital glue, okay, that streamlines those services and brings them all together. Let me just give you an example. It's not an example from mental health, but it's a personal example. I joined the gym, right? The problem with joining the gym is that you then have to go to it, right? And traditionally when I join a gym, I join it and don't go. But with this gym, Pure Gym, they give you an app. And the app in this example really glued the whole service. Because when you download the app, straight away you can book classes, right? Spin classes and boxercise and circuits and so on. And what I found is that it took no effort to book classes. But that really made a mental note that I must go to those classes, right? And by making it really easy to book classes in this kind of anonymous way, I didn't have to make a phone call or anything like that, I then find myself going to them. Now, this is something known as gateway habits that James Clear talks about. A gateway habit is something like, instead of focusing on running, just focus on putting on your trainers. Gateway habits, get the habit of doing something that's easy to do. And for me, it became a habit to book classes, okay, which then forced me to actually go to them. And I thought this app really glued the whole service because it then gives you rewards for achievements. It then lets you see your activity. It also takes you through some regimes as well that are very convenient to use. Now, if anybody has spotted it in the screenshots of my gym app, it says that I haven't been to the gym this week. That's because I've been here, right? So don't judge me, but I will return. So the idea of gateway habits through this digital app has really improved my engagement with the service, which is a traditional service. So this app has been the glue for me. So that's all of the reasons, and there's many more that we could talk about, but that's the kind of case for digital mental health that I would want to make. If I have time, I also want to go through a case study, which is our ChatPal app. It's a chatbot that you can download for free on Android and Apple. The chatbot is also available in different languages: English, Finnish, Swedish, and Scots Gaelic. What is a chatbot? A chatbot is just an app that allows a user to have a conversation with a computer, right? And you might say, well, who wants to talk to a computer? Well, actually, we talk to alarm clocks, and we talk to ourselves, and we talk to all sorts of pets and so on. So the ChatPal app has a lot of features that you can see here, and they're everything that you would expect, like mood logging and psychoeducation and so on. These features came from workshops, which we then put onto a digital whiteboard, and we got people from different disciplines to rate the importance of these different requirements or these different features, which then allowed us to prioritise the requirements. The really useful thing about doing this is that the ratings were completely independent and anonymous. So we didn't know who was rating what in the consortium. So it allowed us to have independent voting and independent rating of features that we then used to integrate into the chatbot. I've already covered a lot of this. The benefits of a chatbot are similar to the benefits of digital mental health, except to say that a chatbot is arguably more intuitive to use because it doesn't have a complex graphical interface. The approach we took for ChatPal was a user-centered design approach. No, we didn't. We took a stakeholder-centered design approach. So I have been drilling user-centered design for a long time, but it occurred to us during ChatPal that this isn't the right perspective. Because if you focus on user-centered design, you might provide something that users want, but it might be something that AI can't do, and it might be something that mental health professionals may not prescribe or endorse. So it's really important to be conscientious of the other stakeholders when designing a mental health intervention. And of course, you would have heard the old adage of Henry Ford, who said that if you ask people what they want, they'll say a faster horse. But of course, what they needed was a car. Okay, so stakeholder-centered design also reminded me of my coffee machine, because we love coffee in our house, and we have different types of coffee machines depending on how much time we have to make coffee. But if you really need coffee fast and it has to be of decent quality, we use a coffee machine where you put in a capsule and you press a button, right? And that's really convenient. That is user-centered design, because I didn't have to put any effort. I get a good cup of coffee within seconds. Now, a stakeholder-centered approach would look at that and go, actually, as a result, you end up drinking too much coffee and overdosing and having poor sleep hygiene. And actually, perhaps the capsules are not good for the environment. So the environmentalists are stakeholders here, and they weren't considered, perhaps. So there's other stakeholders that should be considered in design. So this is our approach. We want to design ChatPal, which should be an intervention that people need, but it should be an intervention that mental health professionals endorse, and it should be an intervention that is reliable. That is, that the technology can deliver reliably. So we did do a survey with mental health professionals, and they were overwhelmingly supportive of the idea of prescribing chatbots. They also told us that they would endorse a chatbot that delivered self-management and psychoeducation and training, but they wouldn't necessarily support a chatbot that was any way diagnostic. So of course we developed a chatbot that was more about promoting mental well-being and more about psychoeducation as opposed to delivering treatment or any type of diagnostics. They also seen the kind of benefits that you would get with a chatbot like this. They said that it would reduce travel time or unnecessary travel, and it would help users better manage their own mental health. So going through this whole stakeholder-centered design, we were able to make some responsible design decisions. One was that we avoided over-anthropomorphizing the chatbot, because we didn't want to deceive people into thinking that they were talking to a human when they're not. So it's important to have full disclosure that this is a computer. We also disclosed the chatbot's capability. So we kept reminding the user that this isn't an intelligent agent. It is a chatbot, and it has many limitations. We always had the fallback message of referring people to helplines, if indeed they thought that was appropriate. And the actual conversations or the scripts in the chatbot were designed by mental health professionals and mental health experts in our consortium, which is also a challenge, because none of us are trained to write scripts unless you come from the film industry or drama or something like that. But none of us are trained to write high-quality conversations. So that was an interesting new experience for us, and we had a nice talk from Heidi yesterday on that. So our chatbot has been trialled through a 12-week trial, and we did have an outcome. We did measure mental well-being using the Edinburgh Warwick scale, or the Warwick-Edinburgh scale. We had 348 participants. We had over 29,000 interactions with the chatbot. And the top 4 features in the chatbot were the thoughts diary, treat yourself like a friend, information about physical health, which is interesting, and activities to help you relax. Now, most of our users were female, and we had a wide range in terms of age. And we only seen a small improvement in mental well-being, although this improvement was not statistically significant. Now, back to the aggregation of marginal gains. Remember, we just want to be transparent. In the results of this trial, we did not see a statistically significant improvement in mental well-being, but the raw numbers do show an improvement, but it's not significant. But back to the aggregation of marginal gains. This app, combined with other digital tools, combined with other services, might have a significant effect. So there's lots of more research questions that we need to ask. As a result of this project, which comes to an end this month, we have published a book which is freely available outside. In this short book, we describe all the recommendations that we provide to you when designing a health-based chatbot. And this is all the learnings from our own project. And we even provide a nice checklist that you can use when designing your own intervention. But of course, there's challenges. Are we promoting screen time? Are we promoting or reducing human support? So these are the type of challenges that we need to think about. Because obviously sleep hygiene is really important for mental health. But if you're promoting people to use a screen during the night or late at night, then you're just promoting even worse sleep hygiene. The other big challenge in digital mental health is the quality of these apps that we were talking about. 28% of health apps are indeed mental health apps, but only 29% of mental health apps would meet the ORCA quality threshold. Now, ORCA is a UK company that assesses the quality of health apps rigorously with lots of questions. They assess the information and clinical assurance, they assess the data privacy, and they assess the user experience. So they rigorously assess these health apps. But only 29% of mental health apps would pass their quality threshold. So we're actually working with ORCA on a project around measuring the quality of apps. And I can say that from our recent work, we're actually showing that the user ratings of health apps and the popularity of health apps don't correlate with their quality. What I'm saying is that users might rate an app highly, the app might be very popular, but might be poor quality. So that's a challenge, that's something we need to think about. There's a whole bunch of ethical challenges when it comes to chatbots. In particular, one is the idea of pseudo empathy. The chatbot doesn't really care, but the mental health experts who wrote the content do care, but the chatbot itself doesn't have any type of emotions. In a way, it's psychopathic. But, so it's not real empathy, and we need to be really careful that the user doesn't think they're talking to a human. Right. So in our ChatPal project, we reinforced that this was a computer and not a human. There's other things to consider, like when a chatbot delivers recommendations, we might legitimize those recommendations or accredit higher value or trustworthiness to those recommendations simply because it's in a conversation. Whereas when you're searching for content on Google, you kind of have that autonomy to pick what content you read and consume. But in a chatbot, you might subconsciously legitimize and overtrust the kind of content that it's delivering. And of course, be careful about reading health books. Okay, the other challenge is user retention. Most people download an app and delete it within a few days. So what can we put into our digital mental health apps that retain the users? Do we put in peer support? How do we put in more valuable content for repeated use? The other challenge is, of course, the challenge of change management. And a colleague and I, Morris, who's with us, we were in the airport and we've observed this a number of times. You can have people queuing up in large queues to a check-in desk, and right beside them are these automated check-in desks where you can check in your own bag and go to the bag drop yourself. So because people, and because we are creatures of habit, we're more willing to sacrifice 25 minutes queuing up in a check-in desk than simply taking 5 minutes to learn this automated process. And so these are a couple of great quotes, I think, to highlight change management. So projects, indeed digital projects, are 5% technology and 95% change management. And sometimes we spend all the money and effort into digitalization, but what time and effort do we put into change, right? And convincing people to adopt new technology. And of course, I came across this in a document, and I think it makes a good point, that there seems to be no party for people who adopt the new technologies. The party seems to happen for those who develop or recommend the technologies. Okay, so if I have time, and somebody will tell me otherwise, I'll just mention a few things about mental health data science. So up till now, we've talked about digital mental health interventions. We also do data science, right? Which is the use of machine learning and data. To give you an example, we started out analysing helpline data, caller data. It's anonymous data. It is very basic data. It just tells you the date and time when somebody called, the duration of the call, whether the call was answered or engaged, and so on. Very simple data, but we had over 3.5 million call log data. Now that allows you to look at the time series of calls to a helpline, of course, and you can look at the volume of calls per hour of the day for each day of the week, and you can see that most people call at in the late evening, right? Which is maybe what you expect. Some people call at 1 a.m. and so on. But you can see that people also, or more people seem to call on Sundays as well, late at night. But what we also do is something called clustering. Just put your hand up if you've heard of clustering. Okay, great. So there's a few people in the room that have done clustering. Now, all clustering does is allows us to discover the phenotypes, or the archetypes, or the types of callers, right? If you only had 2 characteristics from the callers, you could do a scatter plot, right? If you only had 2 characteristics, such as the frequency of calls and the average call duration, you could put that on a scatter plot like this. And you can see that there's likely 3 groups in this scatter plot. So each dot here represents a caller, and each dot represents their frequency, the number of calls that they make, and their average call duration. And as I said, you can see that there are 3 groups. In a scatter plot, then you can identify those groups, and then you could describe the center, that is the centroid, what we call the phenotype or the archetype. And by describing the center of each of these clusters, you're identifying the 3 types of callers in the service. And you can see that there's a small group of callers, the 3, that have a lot of calls, but those calls are typically of low call durations. And you can see in the red group, which is the largest group, that have long calls, but only a few of those calls. Now, this is a hypothetical example. It's not the real data. I'm just giving an example of what clustering is. But the problem is that when you want to characterize callers or any client or user with multiple characteristics, you go into hyperspace, and therefore you can no longer use a scatter diagram. You have to use mathematics. And so we characterize callers using 3 or 4 characteristics and do what's called clustering, which is a data science technique. It's a bit like shapes. You have lots of shapes here. There's many characteristics of these shapes. You've got color, you've got number of sides, you've got the area and perimeter and so on. If you put that data set, the shapes data set, through clustering, it will identify the 3 groups that we get here, which allows you to study the archetypes. So that's what we did with the Samaritans data set. We characterized all colours, which were 61,000 colours, and we put them through clustering and discovered these 5 types of colours, which I'll not get into right now because we don't have time. Laurie's giving me funny looks. We then looked at how can we predict the colour types based on their first 4 calls. Can we predict if somebody's likely to become a high-frequency colour? And we could indeed predict that with a good degree of accuracy. We then looked at the reasons at which people call a helpline. This wasn't Samaritans, it was Lifeline. Because somebody might call today with a particular reason, and then the same person might call next week with a different reason. So we used association rule mining to find out what presenting reasons commonly co-occur, which was really interesting. These are the common reasons, but what we found is that you might have people calling about information, so they're information seeking, but indeed their next call might be about suicide intent. Right, so you can see their first call, they might have been suicidal, but they didn't reveal it. And they used information seeking as perhaps just a different reason to call. We did do some helpline analysis during COVID. We found that during COVID, people called for longer in the later evening. And I'll finish here to say that we do have other projects, one of which is speech analysis, so that if you talk to a smart speaker, for example, you can do speech analysis to try and predict the mood or the mental health score of that client. And that's called the Momentary project, which is something you might want to check out. Laurie, I'm more or less finished. I've just about 200 slides left. And what I would say, just in closing, is that you will see lots of applications of deep learning and AI coming out in many healthcare fields. I don't think the singularity is near. I don't think AI is going to supersede human intelligence. That's just my own personal view. This is an example of a neural network. And you can see that it can make perfect classifications of the writing of numbers. But indeed, you can't explain why it's classifying those numbers. But actually, I believe in talking to doctors that there are lots of drugs that you actually don't know the reason why they work. You just know that there is a cause and effect. So sometimes explanation isn't always that important, but in our field, we believe if you're using a computer for something, you should know why it predicts a certain class. And I will leave you with a couple of really good quotes that I think are useful. That is that AI is a machine that can make the perfect chess move when the room is on fire. Thank you.
Thank you very much, Ray. And I'm really sorry that we need to move on with the program. But before you go, I must say to you, as I am a mental health professional, you said that, and we know that you are a computer scientist. I think that your thinking is very mental health and human, and that's wonderful, because we need to do these applications together, like you said, not just mental health people alone or computer scientists alone, but together, like we are doing here, everything together. I have a small gift for you, chocolate.
Fantastic.
From Finland. Thank you very much.
Thank you.